Start and then. Good morning, everybody. I am Dr. Uday Kiran. I am teaching GIT for you. So, in the last class, we have discussed about viral hepatitis. We have covered viral hepatitis A, hepatitis B, acute, and some points about chronic hepatitis. So, in this class, we will be discussing, we'll be brushing our concepts about chronic hepatitis B a little bit further, and we'll be learning the treatment part of hepatitis B. After that, we'll be discussing hepatitis C and hepatitis E. We'll be talking about hepatitis D also. So we have covered the clinical features of hepatitis B, natural history, like the different phases. We'll be talking about it again, acute and chronic hepatitis B serology and the serological course. So we came up till here, the chronic hepatitis B, different phases. So I'll be brushing the phases of chronic hepatitis B infection again. So as we have spoken in the last week, there are 5 different phases for chronic hepatitis B. Now, in every patient, we may not see all these 5 phases. We may see some 4 phases, 3 phases, depending upon the immune status of the patient. They may progress in this order, or they may skip some steps directly. So, this immune tolerant phase, we are speaking, this is seen in children that are infected by vertical transmission or during postpartum time. If children are infected at a very early age, during the neonatal or during birth, or from the mother itself, in the in vitro, in utero. So you will have immune tolerant phase. What is this immune tolerant phase? Because the virus is already replicating in the neonate, the immune system of the neonate thinks it's a self antigen. It will have tolerance towards the virus. So there will be no inflammation. There will be no antibody production, and hence, because there is no antibody, there will be no inflammatory reaction also. So you can these patients will not have any inflammation of liver, so the liver enzymes will not be elevated in this. So here you see the liver function tests are normal, and the antigen is positive, but the antibody is negative. There is viral replication, but there is no reaction of the body towards the virus. So HBE antibody is negative, and because there is viral replication, your DNA titers are also high. When you do a liver biopsy, there will be no hepatitis. You may see virions within the liver parenchyma, but there will be no hepatitis in these patients. So this is the immune tolerant phase. It usually lasts for 10 to 20 years. Until adolescence, the patient will be in immune tolerant phase. So this patient, if he has got infected at this young age, will be in immune tolerant phase until his adolescence. After that, he will proceed to immune clearance phase. Whereas when adults are infected, they directly proceed to immune clearance phase, totally skipping the immune tolerant phase. Whenever an adult is infected by HBV, his immune system straight away recognizes it as a foreign antigen and starts inflammation. So, immune clearance phase, when a child progresses to immune clearance phase or immune tolerance phase, adult directly enters the immune clearance phase. What is immune clearance phase? The immunity of the adult recognizes that there is a foreign antigen in the liver. It starts producing antibody. There will be antigen antibody reaction, and will be inflammation in the liver, and hence hepatitis. So because there is destruction of liver because of this inflammation, you'll also have liver enzymes released into the blood, and hence the liver enzymes are elevated. So at this stage, if you do a liver biopsy, you will see hepatitis, and because of the ongoing hepatitis and repair, then you can have fibrosis, that is cirrhosis. You can see hepatitis and cirrhosis both. So from the immune clearance phase, the patient can proceed to inactive carrier phase. Can proceed, not must. Not every patient from immune clearance phase proceeds to inactive carrier. Only some people proceed. What is inactive carrier state? In this state, the inflammation or immunity is successful in preventing the replication of the virus. Is successful. It doesn't completely eliminate, but it has limited the viral load of the patient. So in this patient, HBeAg is negative. The pre-core antigen is negative because there is not enough proliferation. The antibody is positive. DNA titers are low but are still present. And because the viral load has come down significantly, there is not much inflammation in the liver. So your liver function tests are also normal or near to normal. So when you do a biopsy in this patient, there will not be significant hepatitis because there is no inflammation. The patient can have cirrhosis because he has been having hepatitis since longer period. The patient may be in cirrhosis, but at present the inflammation is less, so hepatitis part is less in this patient. So that is inactive carrier phase. So here we'll see in this slide, see. Whereas perinatal infection directly proceeds to immune tolerant phase, an adult infection directly proceeds to immune clearance phase, not immune tolerant phase. So this immune tolerant phase in children can proceed to immune clearance phase. From this, because of the ongoing inflammation, the patient will have cirrhosis. But where does this patient go from here? So he may go to inactive carrier state. What is inactive carrier state? So we have seen what is immune tolerant phase, immune clearance phase. Now we will talk about inactive carrier phase. Inactive carrier, we have already seen the patient's inflammation has come down, viral load has come down, antibodies are positive. So this patient may directly go into resolution. The infection may totally resolve. When do you say that resolution has happened? When the surface antigen also becomes negative, you call it resolution of the infection. So we'll talk about reactivation later. We'll directly first see about resolved hepatitis. So these patients, because of the ongoing onslaught of immunity on this, the patient may eliminate the surface antigen itself. At this stage, patient is not infected to anybody else. Whereas in inactive carrier phase, the patient might be still infected. The infection rate might be less, but the patient is still infected. But when the resolved hepatitis patient, the patient is not at all infected. The HBV DNA titers are totally undetectable. Surface antigen is also negative, and surface HBs and AG. AG is negative, and HBs AB is positive. Antibody is positive. Because the virus is totally eliminated, the patient is now having no hepatitis and normal ALT levels. So in these patients, these patients are not infected to anybody. So the patient may directly go from inactive carrier to resolved hepatitis. So what about this reactivation? Some patients from this inactive carrier phase, after you think that inflammation has come down, may still progress to reactivation. Again, the liver enzymes will increase, DNA titers will increase. So why this has happened? In these patients, either immunity has come down because of some problem, or most importantly, this patient has developed a pre-core mutation. That is, that hepatitis B antigen has mutated and it is being no longer produced. So whenever this antigen is no longer produced, the immunity of our body cannot recognize that antigen anymore and cannot fight the infection properly. So what happens in these patients? The antigen is negative, antibody is positive. Hepatitis B antigen negative, hepatitis B antibody is positive. And DNA titers are elevated and liver functions are also elevated. There is inflammation, not necessarily against hepatitis B antigen, but there is inflammation because of the ongoing viral replication. So these patients again will start increasing of LFTs, but HB antigen is negative. Okay, this is seen mostly in pre-core mutations. So we have seen about resolved hepatitis, all this chronic infection. Serological course. Now we go to treatment. So there are different phases of infection. Like we have seen how the infection progresses in children and adults. So when do you treat a patient of hepatitis B? So first thing we need to see if the patient is having hepatitis, not acute, chronic. Acute hepatitis can resolve on its own. 95% of acute hepatitis patients will resolve on their own, so we don't give treatment to them. There are exceptions, I'll tell you them. So, but in a patient of chronic hepatitis, whenever there is ongoing hepatitis with liver enzyme elevation, we'll treat that patient. Okay. Whenever there is cirrhosis, even if there is no active hepatitis ongoing, but there is cirrhosis and there is DNA present, we'll treat the patient, because this patient may go into hepatitis at some time later because of reactivation or something. And when that happens, already the liver is cirrhotic, the reserve is small, we don't want this patient to go into hepatitis. That patient also will treat at a lower threshold of DNA levels. So this is the basis of it. Whenever there is hepatitis, we'll treat. Whenever there is cirrhosis, even when there is no hepatitis, like milder hepatitis, we'll treat. Okay, so see here. So this patient, so a children may come in immune tolerant phase, or an adult may come in immune clearance phase, whichever phases the patient may come in. If the ALT is persistently normal, if the ALT is normal, we'll wait, we'll not treat. Okay. So see, if the ALT is persistently normal, that means there is no active hepatitis going on. Even if the HBAG is positive, HBV DNA is greater than 20,000, we don't treat this patient. Why? Because once you treat the patient, it doesn't necessarily mean that the patient is cured. Hepatitis B suppresses the viral load but doesn't completely eliminate the virus. The patient is not cured. So what we want, so in immune tolerant phase, there is no immunity working. You are giving your drugs, the viral DNA comes down, but as soon as you stop the treatment, again the virus comes back, because there is no immunity to help you fight the virus. So in these patients, you usually don't treat the patient, because see, you treat the patient, the viral load comes down, but the virus retains resistance to the drug, and you cannot use any other drug. And actually, when the patient start having immunity and hepatitis, there is no drug available for you to treat, because there is already resistance for the drug. So what you treat in this do in this patient, you continue to monitor regularly, like how is the viral DNA load, is there ongoing any hepatitis. Every 6 months you keep doing ALT and AST levels, and you also look for hepatocellular carcinoma. Even when there is no hepatitis virus itself can cause carcinoma, so you will also be checking for carcinoma in this patients. This is immune tolerant, you don't intervene, you check for, you serially monitor the patient. So ALT is, so the other part, the HBeAg is negative and DNA is also low. This is called inactive carrier phase, as we have seen. Still HBsAg is positive, but HBeAg is negative and HBdNA is very less. So there is no hepatitis going on in this patient. There is no need to treat this patient, because there is no hepatitis only. The patient may go into resolution phase directly. But you keep monitoring again, you keep seeing that you should make sure that the patient is resolved or has reactivated. You need to see if the patient has reactivated, then you should treat the patient. So if these patients need 6 hourly monitoring, 6 monthly monitoring. So next thing is, so in these patients, if the ALT is high, that is there is active hepatitis going on, you need to treat these patients. So in this patient, the hepatitis, this part of the algorithm showing HBeAg positive and HBV DNA greater than 2000. So definitely you treat this patient, because there is hepatitis and the risk of progressing to cirrhosis is higher. So other cause of liver diseases we will find out. We'll do a liver biopsy. We'll see if there is another virus, other viruses going on. We'll see if the patient is alcoholic and if alcoholism is actually causing all these infections. But no matter what, if there is enzyme elevation and if there is more than 2000 of DNA particles, you treat the patient. Okay. And not only you treat the patient, you keep on monitoring for liver carcinoma also. Every 6 months you do an ultrasound, and if you see if there is any new mass developing in the liver. So other thing, like we have said, reactivation. These patients are actually HBeAg negative, but still your DNA is more than 2000. We have seen, right? We have covered this part. Why this is like this? HBe is negative, HBdNA. Here we have seen this reactivation phase. HBeAg will be negative, but DNA titers are moderately high and elevated liver enzymes. So in these patients also, you do the same thing. You treat the patient with antivirals, and you keep checking for the uh, 6 monthly surveillance for hepatocellular carcinoma. So what does differ in between these two patients? So these patients, the pre-core mutant patients, they may not resolve ever. because there is no hepatitis antigen antibody reaction to help you cure the virus. These patients may never resolve actually. They may require lifelong treatment. Whereas these patients, this part of algorithm where the HBeAg is positive, your immunity may be successful in eliminating the virus when you have suppressed the viral load. So these patients may totally resolve and HBsAg may become negative and HBsAg antibody may become positive. So these patients, you maybe at some point of time you can stop the treatment. In these patients, you can never stop the treatment because there is no help from the HBe antigen. Okay. So what is the treatment that we give? Acute hepatitis B is usually supportive care because 95% of the patients usually resolve. Only 5% will go to chronic. When they go to chronic, you treat them that way, like chronic hepatitis B. So how do you treat in acute hepatitis B? Usually it is supportive, like you said, like coagulation factors are less and there is multi-organ dysfunction, you support them. When do you treat? When there is fulminant hepatitis failure leading to hepatic encephalopathy, then in these patients there may be some help from the antiviral drugs. Only in those patients use. If it is subclinical or if it is not severe, there is no point in using antiviral drugs. So chronic hepatitis B, like we said, when to treat we have already seen. What to treat with? One is pegylated interferon alpha, lamivudine. These are nucleoside agonists. Analogs, sorry, nucleoside analogs. These drugs are the lamivudine, adifovir, tenofovir, and entecavir. So these are all nucleosides, but pegylated interferon alpha is a biological. So what does pegylated interferon alpha do? It actually boosts your innate immunity to attack the virus. Rather than decreasing the viral load directly, this increases your immunity, fight against the virus, and decreases your viral load indirectly. So what happens actually transiently, if you give this pegylated interferon, your immunity increases and the inflammation actually increases because your body is fighting the virus more and collateral damage of liver happens and your AST LDL levels are initially elevated. Whereas these nucleoside inhibitors, they directly act on the virus. The viral replication is inhibited, the viral levels come down. So you don't see any AST, ALT increase. But what is the advantage of pegylated interferon? Because it's only your immediate immunity getting boosted and fighting. The chances of clearance of virus permanently are more with interferon. Whereas with lamivudine adifovir, the permanency of that resolution is not present. Initially, the viral load comes down, but as soon as you withdraw the drug, the virus may come back because it has never got cured. So, what are these different advantages and disadvantages? Like I told you, this may help in cure, but it increases your inflammation. So, where do you not want this inflammation? When the patient is already having cirrhosis, that means already a lot of the liver is damaged, you don't want to cause more inflammation. In that patient, you don't use interferon alpha. In that patient, you use nucleoside inhibitors. Whereas in adults and adolescents, you can use pegylated interferon alpha. Nowadays, they are using in combination with these drugs. You decrease the viral load and you give interferon alpha also. You may achieve more HBs antibody positivity more. You may result more resolution. Okay. So coming to this is treatment, medical treatment. So now that you have hepatitis and cirrhosis, the patient's liver is totally damaged. What will you do? You go for liver transplantation. Even post liver transplantation, the patient may still have the virus. You can continue to treat with uh, nucleoside inhibitors. Okay, because you pegylated interferon, you don't give post transplantation because pegylated interferon increases inflammation and immunity. After you transplant, the transplanted liver itself is a foreign body. If you increase the interferon and give the immunity, boost the immunity, liver itself may go damaged. So you give only nucleoside inhibitors post liver transplantation. Now coming to the prophylaxis. You all are medical students, must have got your immunoglobulin course. Not immunoglobulin, I mean vaccine course. You need 3 doses, right? So usually nowadays they are prescribing itself for children itself. They have included in the national program of immunization. In adults anyway, 3 doses, 0, 1, 6, okay, months. So what happens? So we'll deal with special condition here. So a child is born to an already HBsAg positive mother. What do you treat? The patient is already having the virus. What is the point of giving the like vaccine at that time? So what you do is, on one side, on one arm you give immunoglobulin. You want to bind the virus. That is all. The full virus that is present in the body, you want to bind it with immunoglobulin. And on the other arm, what do you give? HBsAg antigen you give. That antigen may protect from further infections. You remove the virus with the immunoglobulin and give an antigen to increase the immunity, so that his body recognizes the infection, and if at all whatever is present can be eliminated. So you give one on each arm, not both same, because if you give immunoglobulin on the same arm or the same leg and antigen also on the same leg, like vaccine, both will get binded and neutralized. So on one arm you give immunoglobulin, on the other you give antigen. Okay. So coming to okay. Okay, that's it. That's about the immunoprophylaxis. And also you give immunoglobulin in high risk patients, like somebody is having chronic renal disease. These patients' immunity is low. In that patient, you give hepatitis B vaccine, double the dose. So that's about hepatitis B. Now we will come to hepatitis C virus. Before we come to hepatitis C, we'll directly go to hepatitis D and come back. So why are we dealing with hepatitis D infection at the same time? Because hepatitis D usually it occurs along with hepatitis B virus. Okay, it cannot survive on its own. It needs some other virus, some other viral machinery like DNA polymerase, RNA polymerase, that proteases of hepatitis B to survive. So the mode of transmission is also the same, like injection drug abuse and sexual transmission. So when does this hepatitis B infection, hepatitis D infection arise? It usually occurs along with the hepatitis B infection or over already existing hepatitis B infection. Okay, that is called co-infection. Simultaneous infection is co-infection or super-infection when there is already pre-existing HBV infection. The incubation period is 35 days. What does this hepatitis D do? It worsens the already present chronic hepatitis. Okay, so what do you see? I already see that there is the serological profile of hepatitis B. We have already seen. On top of that, you will have anti-HDB also, antibody also. Okay, so the progression of cirrhosis to cirrhosis is faster. There is no treatment for hepatitis D. You treat hepatitis B and hepatitis D get cured automatically because it cannot sustain without hepatitis D. Hepatitis B. Okay. So coming to hepatitis C virus. So hepatitis C virus is an enveloped single-stranded RNA virus. It belongs to the family Flaviviridae. There are 6 genotypes in this virus. That is 1 to 6. In India, number 3 is common. In USA, genotype 1 is common. Why do you need to know if there are different genotypes? Because each genotype has a different treatment and different response to treatment also. So in India, genotype 3 is common. So mode of transmission, this is mostly through blood transfusions and IV drug abuse. Okay. So how did HCV become so prevalent? Before 1980s, there was no universal screening of blood donors. They were not aware of this HCV at that point of time, and everybody was getting HCV transmission. More of these people are that, like hemolytic anemia patients requiring repeated blood transfusions and ICU patients. Whoever got blood transfusion before 1980, those bloods were not screened for HCV, and these patients mostly got infected with HCV. And nowadays, whatever HCV patients you see mostly are from that era who got transfusion at that point of time. People who got transfused after 1980 are not prone to this because there was universal screening of donors at that time. So nowadays, fresh cases are mostly because of the IV drug abuses or needle stick injuries for the doctors. Yeah. So this is the important route. Sexual route is very and vertical transmission has very limited risk, unlike hepatitis B, which is almost 90% transmission. Here you see 2 to 3% of transmission through vertical transmission or sexual route. So incubation period is 15 to 50 days, but the thing is you don't immediately see any symptoms or sign within 15 to 50 days. This is the acute infection in hepatitis C is not symptomatic. It is asymptomatic. Like there may be mild elevation of liver enzymes, but there is no severe active hepatitis ongoing. So you'll have no jaundice, no abdominal pain, anorexia, nausea, vomiting like you have seen in hepatitis B. That will not be present in most of the cases. Some patients may still have severe acute hepatitis. So though the incubation is 15 to 50 days, you may not see the symptoms for much longer. So symptoms are developing until 5 to 12 weeks after exposure. So just like you have seen, acute liver failure is rare. Whenever there are other co-infections with hepatitis B, or if the patient is alcoholic also on top of hepatitis C infected, then you have more symptoms. So clinical features, coming to clinical features, you already see the symptoms of hepatitis, that is fatigue, jaundice, elevated transaminases, anorexia, nausea, vomiting, the usual routine symptoms of liver. So a little bit about pathogenesis now. So chronic hepatitis C infection, once you have an hepatitis C infection, it doesn't resolve on its own at all. Your immunity is not capable of it. Why? There are different mechanisms for it. The most important is hepatitis C virus secretes some mediators that will prevent your innate immunity from attacking the cell. So it survives within the cell, and your immunity, the T lymphocytes or T helper cells or CD8 cells cannot attack the virus. So it escapes the cytolytic activity of CD8 cells. One more thing is this RNA polymerase of hepatitis C virus is not good. So it doesn't exactly replicate like the parent strand. So there are ongoing mutations and the antigens keep on varying. So your immunity cannot recognize it because of the changing antigens. So there will be antibodies, but as soon as the antigen changes, it cannot do anything. So this is how hepatitis C becomes chronic. So now we'll see about the extrahepatic manifestations. Why I have spoken about that pathogenesis, now you'll understand. So one is essential mixed cryoglobulinemia. What is this? Cryoglobulins are our antigens, IgM or IgG antigens, IgM or IgG antibodies produced in excess and get precipitated everywhere in the blood vessels. So why is there excessive production of these antibodies? Because the virus keeps on changing its antigens and is also suppressing cell-mediated immunity. Antibodies are increasing, but there is no antigen to bind because the antigen is already mutated. So there are so many antibodies getting produced, and they get deposited in the blood vessels. So deposited antibodies, they can by themselves activate complement, and you will have vasculitis, inflammation of the blood vessels. That is called essential mixed cryoglobulinemia. And because of the constant stimulation of the lymphocytes, you can have lymphoma. And because of the increase in antibodies and abnormal activation of lymphocytes, you can have lymphocytic sialadenitis, autoimmune thyroiditis, lichen planus, and non-Hodgkin's lymphoma also. These are the extrahepatic manifestations. Hepatic manifestation, we have seen chronic hepatitis, and that may progress to cirrhosis. So here is the natural history. Acute hepatitis infection is asymptomatic. It progresses to chronic hepatitis C in 85% and develops into cirrhosis around 20 years. And because it's definitely progressing to cirrhosis, the risk of hepatocellular carcinoma in these patients is higher. So HCC occurs in 4% and death due to either HCC or decompensated liver disease. So unlike adults, neonatal infection may show 25% spontaneous clearance. Adults will not show 25%, it will be much lesser, some 5 to 10% will show. So here is it. Initially, you will have antigen HCV RNA in the blood. This is HCV RNA, it will be detected right from the beginning. And you will have anti-HCV also. It will keep on increasing because newer antigens will keep coming and anti-HCV is also being produced. It will keep on increasing. So initially you will have some inflammation, AST elevation levels are detected. After that it comes down and there will be fluctuating AST ALT levels. There will be no acute hepatitis. It goes into chronic hepatitis and it will go into cirrhosis after that. So what is the test? There is no specific antigen. You do an anti-HCV antibody. You detect for antibody in the blood. That's how you detect. Even though antibody is present, you are very sure that the infection is also present because the infection never resolves. Just checking antibody is enough. So coming to HCV RNA, you can also detect RNA by the PCR reaction. Okay. So genotyping should be performed because there is different treatment for different genotypes. So we'll do a liver biopsy. So how do you clinically manage? You do a liver biopsy, see how bad is the cirrhosis. So initiate therapy. So at any point of HCV infection, because the HCV infection cannot resolve on its own, you start treatment. Doesn't matter if the patient's ALT levels are elevated, not elevated, the patient is cirrhotic, non-cirrhotic. In hepatitis B, we have taken all these into consideration. But in hepatitis C, you don't take any of this into consideration. You just treat the virus. So based on the genotype. There are different kinds of drugs. We'll talk about the drugs in a little bit. So why do you treat the patient irrespective of the clinical status? See, as I've told you during pathogenesis, HCV virus has the capability to prevent the innate immunity from working, right? So if you decrease the viral load, the inhibition of immunity may come down and the immunity may actually act and eliminate the virus from the body. So that is the rationale behind giving therapy irrespective of the status of the patient. Even in this recurrent HCV infection transplant patient is almost universal, because even in HBV also after transplantation the infection happens, but you can treat with the drugs. There is nothing else you can do about it. So here also you can give pegylated interferon monotherapy. The prevention of immunity of that patient will come down when you give interferon. The immunity gets boosted, and also combination with ribavirin. This is the previous generation therapies. Nowadays we are not giving ribavirin, we are directly going for protease inhibitors. What are the protease inhibitors? The viral polypeptide chain is produced in the liver cell. That polypeptide is very long and it needs to be cut at various places. It needs to be cut at various places so that the necessary proteins are produced. It is done by viral proteases. If you inhibit the protease, the polypeptide chain will never break and the virion will never form. There are different non-structural proteins that are proteases present in the virus. The most important are NS5A and NS5B. Non-structural protein 5A and 5B, these are the proteases. And inhibitors of these 5A and 5B are important for us. So how do you check there is a virological response? Rapid virological response will early virological response, a sustained virological response. So what are these? I don't think you need to know these, but rapid virological response, if RNA PCR comes down, PCR levels RNA come down within 4 weeks after initiation of therapy, called rapid virological response. If it takes 12 weeks, you call it early virological response. And after the virological response, if the virological response gets maintained for 24 hours, we call sustained virological response. So what are the drugs you use? Pegylated interferon, NS5A inhibitors, NS5B inhibitors. Example are sofosbuvir, ledipasvir, valprotasvir. There is a long chain of drugs, huge list of drugs. You need not remember at undergraduate level. You just need to know the different classes of drugs. Ribavirin is a nucleoside inhibitor. The other drugs are protease inhibitors. Okay, so that is about HCV. There is no prevention of it, just taking universal precautions. Even if you have a needle stick injury, there is nothing you can do about it. You cannot give an immunoglobulin, because immunoglobulin itself will not work. Your antibody itself will not work against the virus. So you need to wait and keep on checking the liver enzyme levels for every 3 months and see if you have raising RNA levels. You need to get treated the same way as a patient. Whereas in a hepatitis B patient, if you have a needle stick injury, you take immunoglobulin and also HBsAg immediately after the needle stick injury. Coming to hepatitis D virus, we have already covered. Coming to hepatitis E virus. So this virus is important in the pregnant patients. It is notorious to cause cholestatic hepatitis in pregnant patients, and also has high mortality within them. So what is the mode of transmission? It's a fecal-oral route, just like hepatitis A virus. You'll have epidemics in local communities. The incubation period is 2 to 9 weeks, affects mainly adolescent adults and mainly pregnant women. This is self-limited. So usually if some normal patient gets HEV, you give supportive therapy only, nothing else to do. But in pregnancy patient, this may progress, this may worsen and may need critical care management. And also that's why you see high mortality for pregnant women. There is no chronicity in this hepatitis E virus. So what are the viruses that don't have chronicity? One is hepatitis A, one is hepatitis E. These are self-limited. Fecal-oral route transmission, self-limited viruses. Hepatitis B and C can progress to chronic hepatitis and cirrhosis and hepatocellular carcinoma also. So whichever go chronic will cause you cirrhosis and carcinoma, whereas hepatitis A and E cannot cause you uh, cirrhosis and hepatocellular carcinoma. So what do you do when somebody is having cirrhosis? You also need to vaccinate about against hepatitis A and E, because cirrhosis patients will go immediately decompensated, because already the reserve liver reserve is less. Whenever they have an acute hepatitis from any cause, they'll go into decompensation. So you need to vaccinate them also against these viruses. So that's it, guys, about acute viral hepatitis. So in the next class, we will be discussing about alcoholic hepatitis and maybe non-alcoholic and NASH, non-alcoholic steatohepatitis. Okay, thank you.